So hi everyone, this is one of our webinars for Cancer ABCs from the Prostate Cancer ABCs conference. This conference was scheduled for March 21st in Florida, but because of the current situation with coronavirus, we turned everything into virtual webinars. So we will be recording this webinar for you. This is a joint effort between Prostate Cancer ABCs and a company called Informed DNA, who graciously supplied us a speaker. Her name is Susan Thompson. She is a certified genetic counselor. So we're really, thank you to Informed DNA and thank you to Susan. This is April 2nd, 2020. Few things about how we want to do this. My name is Jan Manwright. I'm the Executive Vice President of Cancer ABCs, and I have Joel Nowak with me, who is the CEO and co-founder. We both have experienced cancer significantly in our lives, and cancer crisis, to be really candid. But we're both convinced that we learned so much that we're compelled to pay it forward. So taking that as non-medical professionals, which we are advocates and educators, but not medical professionals. This is how we're going to do the webinar, and this is what lines up with our mission statement for Cancer ABCs. We will not and cannot advise a treatment for you. This webinar will be mostly about testing, but it will begin to talk about treatments. And I just want to be clear, we won't do that. There's several really important reasons for that. And honestly, one of them is if our goal is to empower you, once we begin to give you advice, there's a certain element there where we've taken the power away from you. What we'd like to do instead is to equip you to make the decisions that you really want to make. And we're going to do that by helping you to understand your own situation better when we can, and if we can, because every prostate cancer is different. And genetics alone is one of the things that illuminates that for us. Our goal is to help you understand both risk and benefit of tests or treatments. Most of this will be about testing, genetics testing, and again, hereditary genetics, not tumor genetics. Our goal is to help you, this is where we can really help you develop better questions for your doctors, your nurses, your pharmacists, and your genetic counselors, if you have access to one. And the funny thing is that better questions will get you better answers. I experienced that personally for 13 years with my husband. We beat every odd you could have thrown at us regarding his prostate cancer, and Joel has a very similar story. All of these things will help you engage better, this is our hope, in shared decision making. Shared decision making is a really important term that I'd like everybody to know. That's because it sounds like really obvious. Clearly, it's people sharing decisions, but it's actually a medical term written into prostate cancer guidelines in 2017 for all your urologists, all your medical oncologists, and all your radiation oncologists. So you can actually turn the conversation in a clinical appointment with your doctor by saying, I really would like to do shared decision making with you, and use those terms. I've seen it happen more than once. What you're saying is, I want to share in the decision with you, doctor. I want my wife to share, my partner to share, and I want to share as a patient. And that one phrase can actually help shape your conversation with your doctor. So keep that term, circle it, write it down, shared decision making. It's a valid medical term. I'd like to thank our sponsors, our support for today. These are two companies. There's several more, but these are two companies that offer this Germline hereditary genetic testing. This is, as Susan will explain, testing for what you carry, not what your tumor expresses. It's usually done through a blood test or a saliva test, and I'll let Susan elaborate on that more. But these are two companies that do offer the test, and we'd like to thank them for their support today. Regarding Q&A, questions and answers, here's some tips that I think can help. I use these for all the conferences that I've organized. Shorten your question if you can to, a bullet point, not a paragraph, but do that by finding the most important thing that you really want to know. Also, take notes as Susan is talking, because you may find that your question is answered before you even ask it. And you should have handouts that I emailed to you. If you want to print them out, so be it. If not, grab a piece of paper. Definitely have a pen and paper handy. When you ask your question, if you can frame it in your personal cancer situation just a little bit without giving the whole story, that's very helpful. And I've already touched on the fact that we cannot give medical advice, so I think that part's clear. So at this point, I'm excited to turn this over to Susan Thompson, MS. CGC stands for Certified Genetic Counselor, and she's going to take us from here. So Susan, it's all yours, and thanks for joining us today. Thank you to Informed DNA.
Great. Well, I'm very happy to be here with all of you and can share this information on hereditary prostate cancer. I've been working in the cancer world for about 18 years, and we definitely have come a very long way in that time. So this is kind of a snapshot into where we are today in 2020. So just a disclaimer, so I am a full-time salaried employee of Informed DNA, and we are a genetics company that specializes in genetic counseling and genetic services. So what I want to talk with you about today is just to kind of talk about the difference between inherited versus non-inherited cancer risk, when someone should consider having genetic testing done, what genes are involved when it is inherited prostate cancer, and what the impact of genetic testing can be for you, the patient, and also for your family members. We'll go through a couple of case examples and what this looks like in real life, and then I'll talk about a couple of frequently asked questions when it comes to genetic testing and what the next steps could be for you. So when we think about cancer in general, all cancer by nature is genetic, but not all cancer is actually hereditary. And so there's a big difference in those two things. So all cancer being genetic means it happens because of genetic changes that happen within the cell that makes the cell not be able to work correctly anymore. Those genetic changes make the cell turn into a cancer cell, and it doesn't recognize what it's supposed to do anymore. So that's different when the cancer is hereditary, because usually those genetic changes are acquired over somebody's lifetime. The cell starts out normal and then acquires those genetic changes over a lifetime. When cancer is hereditary, a person is born with a genetic change that doesn't give them cancer right away, but it increases their risk of developing cancer. So when we're talking about inherited cancer or cancer being hereditary, we're really talking about the risk being inherited for a particular type of cancer. If we can go back one slide, that would be great. So I just want to make sure that we're all kind of on the same page and speaking the same language. When we talk about genetics, our basic genetic material is called DNA. And I'm sure you've heard that term before, but sometimes it's kind of confusing to know how all of this information works together. But basically, our DNA is our genetic code. And a portion of DNA that has a very particular job in the body is called a gene. We have about 20,000 genes, we think, in our body that tell our cells how to grow and divide and function. And we rely on these genes to be working correctly for our bodies to function how they're supposed to be functioning. So when we're talking about the genes, those are something we think about, like these are the instructions, like our genetic code is an encyclopedia of information. And in every single cell of our body, our entire genetic material is included, all 20,000 genes in every single cell. And if we look very closely, we can see packages of DNA called chromosomes, and our genes live along those chromosomes. And if we break it down even further, we can stretch out the DNA to basically know what the spelling of that DNA is supposed to be. So genetic testing looks at the DNA and looks at the spelling of the gene, what it's supposed to be, and determines, is that spelled like it's supposed to be for the gene to work properly, or is there a change in the spelling of the DNA that makes the gene not work correctly? And when there's a change in the gene that makes it not function correctly, they call that a mutation. So if we can go to the next slide. And when we think about mutations, mutations can either be acquired in your lifetime, or those mutations can be inherited. And you may have come across the terms somatic versus germline when we talk about genetic testing. So when we talk about somatic changes, those are changes that occur in just a very specific cell type. So when we're talking about your prostate cancer and determining, are there genetic changes? We expect there to be genetic changes in your cancer cells. Those are all going to be somatic changes. They happened unique to that prostate cancer, and they call those somatic. Those are all sporadic changes. Those have happened, acquired over time. And that's different than germline changes. Those are the ones that are inherited, meaning it happens in the egg or the sperm that created you, and that's going to be present in every single cell of your body. So not only your cancer cells, but also your normal cells. So just a little differentiation. When we're talking about inherited cancer, we're talking about these germline testing or inherited changes versus tumor profiling, which looks at the somatic changes, the acquired changes that have happened over your lifetime. So how much of this cancer is actually inherited or hereditary? When we lump all cancer together, when we're looking at every single type of cancer, we think about 10% of the time it's due to these inherited changes. And again, the cancer is not inherited, it's the risk that is inherited. So we think about 10% of the time. About 60% of the time, this is sporadic. The cancer happens randomly. It's not due to any changes you were born with. These changes were all acquired over your lifetime. And those are all somatic changes. Now, there is a group in the middle that we think of familial. That's where the pattern of cancer in the family, it looks like it should be hereditary. There's either a lot of prostate cancer or features that are suggestive that this looks like it's hereditary in the family. But when we do genetic testing, we can't find any inherited gene changes. And so it's sort of a subgroup that we call it's familial. And we're still studying families that fall into this familial category to figure out what else could potentially be going on. But mostly I'm going to be focusing on the 10% that where it is hereditary. So just to kind of contrast when it is inherited or when it's sporadic, just to review, when the mutations are inherited, you inherit it from a parent and you can pass it down to your children. That gene change is going to be found in every single cell of your body, including your eggs and your sperm or sperm. Men and women carry these mutations equally, and it's in other family members as well. It usually causes a very specific cancer syndrome that has risk for very specific types of cancer, and those risks are increased for those very specific types of cancer. And this is sort of what I specialize in. And it's very different from the sporadic cancer, where again, the mutations are very specific to the cancer itself in the prostate and not present in the other cells of the body. These acquired mutations are not passed down through the generations. Again, they're acquired during somebody's lifetime. And when we think about other cancer risks, usually risk for other cancers that are not related or not elevated. They're usually general population risk. So for the next slide, what does this look like when we look at a family history? What does this look like? So just to kind of orient us to what a pedigree is, some of you might not be used to looking at family trees like this, but just to kind of orient you to what we're looking at. These circles represent females in the family, squares represent the men in the family, and these are the different generations, parents, children, and so forth. And so when a cancer is sporadic, most people, if we draw out a family tree like this for them, most people are going to have cancer somewhere in their family. But usually what we see are very common types of cancers at common ages, or cancer that doesn't really follow any particular pattern. It usually looks kind of random because usually that's exactly what it is. Just random, sporadic cancer. Again, it happens for reasons we don't fully understand yet, but probably a combination of just normal genes that acquire these changes over time, either due to aging or the environment, or sometimes just chance. But occasionally we do see either types of cancer or patterns in the family that make us suspicious that maybe the cancer is not random. Maybe there is a gene that's not working correctly that's being passed down through the generations, and people in the family who inherit this broken gene are going to be at increased risk for very specific types of cancer. And people in the family who don't inherit it, who just get a normal copy, again, they're going to be at average risk to develop a random cancer. So if we compare these two family trees, on the left, we see this is what typically is seen. We see a common cancer, breast cancer, at a common age, or if we put this in the context of prostate cancer, we might see one of the men with a prostate cancer in his 60s. Nothing really else is going on in the family. Nothing else that would be suggestive that this is inherited. It's very different when there is a gene in the family. It usually looks similar to what's going on the right, where we see multiple generations affected. We see prostate cancer with related cancers like breast cancer or pancreatic cancer or ovarian cancer. We can see it with rare cancers like male breast cancer. And so this is a family on the right that has a gene change, a very particular gene change in the gene called BRCA2. We'll talk a little bit more about that one, but this is what it can look like. This is a pretty striking family. Sometimes it's a little bit more subtle than this, but these are the things that I look for as a genetic counselor when I'm analyzing somebody's family history to say, does this look like it could be inherited, or is this more likely to be a sporadic occurrence? And so one of the tools that we use to help us determine, when to consider genetic testing for an individual is something called the NCCN Guidelines, or the National Comprehensive Cancer Network Guidelines. And they have ones that are specific for prostate cancer. And what they tell us is that when someone has a metastatic prostate cancer or an introductal prostate cancer, doesn't matter what age, that's enough to warrant genetic testing for inherited prostate cancer genes. And we'll talk a little bit more about which ones those are. If it's not metastatic, but it has a high Gleason score of 7 or higher, and has some other features in the family that are suggestive that this could be inherited. Like these genes are more prevalent in people who have Ashkenazi Jewish ancestry, or if there's relatives with breast cancer at a young age, or ovarian cancer, or pancreatic cancer, or somebody else in the family has metastatic or introductal prostate cancer at any age. Again, that's enough to warrant testing. Or if there's 2 or more with breast or prostate cancer at any grade, at any age. So the more you have in the family, the more suspicious we are that this could be inherited. So what also sometimes triggers germline genetic testing is when a mutation is identified on the tumor profiling that shows a somatic change that could potentially indicate there is a mutation there in the germline too. So on your tumor testing, if there's a gene identified that we know increases risk when it's in the germline, that's enough to warrant testing to do germline testing. And as Jan mentioned, this testing, when it's germline testing, it's done either through the blood or through saliva. They can get your cells and your DNA through either of those methods, and they are equal as long as they can extract the DNA. So what genes would we be thinking about? And these are all very, very good genes. Again, you want these genes to be working correctly because they actually help prevent cancer from happening. They're protective. So there have been several genes that have been identified in when prostate cancer is inherited. The first group is something called the mismatch repair genes. MLH1, MSH2, MSH6, PMS2, and EpCAM are the 5 that cause something called Lynch syndrome. And Lynch syndrome basically is more frequently known because of its increased risk for colon cancer and other GI cancers like stomach and pancreatic, and for women, ovarian cancer and uterine cancer. But within the last few years, they have really been able to describe that prostate cancer is a part of Lynch syndrome as well. And knowing if you have Lynch syndrome definitely changes medical management if one of these gene mutations is present. So that's the first set. The second set is something called, they're DNA repair genes. So these genes are responsible for fixing acquired mutations in the cell. So these are, again, are very good genes. So BRCA1 and BRCA2 are the most common, but there's also CHEK2, ATM, PALB2, and RAD51D, which have been more widely studied within the last few years. All of these genes have risk for other cancer besides prostate cancer, and especially for women in these DNA repair genes, so for your female relatives, the risk of breast cancer is significantly elevated. So this has an impact for all family members. When we think about HOXB13, this is kind of a prostate cancer specific gene that has been recently discovered and is being studied. And it really seems to only affect men and really seems to be implicated in increased risk for prostate cancer alone. Female carriers of HOXB13 do not seem to be at increased risk for anything. But because there are so many genes that they recommend looking at, usually the strategy that we use is to do a panel test where we look at all of these genes at the same time. And you can do a prostate specific panel, you can do a much larger general panel that looks sort of at all hereditary cancer genes. There's a lot of variety of what panels are available to test. So how often do we find one of these genes? If you remember before, we said about 10% of the time we think cancer is inherited. So they wanted to look at what about in prostate cancer? How frequently are these genes mutations found? And so they looked at a series, this was back in 2016, a series of men with metastatic prostate cancer, and there were 692 of them, and they found that about 11.2% did have one of these inherited germline mutations in a DNA repair gene. And so it's broken down by the specific genes. BRCA2 by far is the most common, but then the others follow suit as well. So that means that 90% of the men about with metastatic prostate cancer tested normal, negative, and we have ruled it out for them and for their families, but for these 11.2%, it made a big difference for their medical care. So they looked at another study because that was looking specifically at metastatic prostate cancer, which is part of the NCCN Guidelines, but what about prostate cancer in general? So there was another group just recently last year that looked really at an unselected population of prostate cancer. So unselected meaning it didn't matter what stage it was, what Gleason score, not whether it's metastatic or not, and unselected for family history. So family history didn't matter either. And they looked at a series of 3,607 men, and they did panel testing for these men. The panels really was it was a range. There wasn't a standard panel. So some doctors only ordered BRCA1 and 2. Other doctors ordered huge panels that looked at everything. But when they expanded the criteria, we also found that there was a higher proportion that had a germline mutation, about 17.2% in this particular study. Again, BRCA2 seemed to be the most common gene, but there were others as well. I think what was interesting, I just want to mention, is that there were 2 genes in here, MUT-YH and APC, that have not been implicated in prostate cancer at all. And so I think this is probably an artifact of just the panel that was done. The MUT-YH and APC genes are usually on there because of the risk of colon polyps and colon cancer. That's what it's associated with. But the carrier rate for MUT-YH in the general population is very high for people who have European ancestry. And if you have just a single mutation in MUT-YH, you are not affected. It doesn't matter at all. It's when you have 2 copies that are broken with MUT-YH. This is a recessive gene. And so to be a carrier is just an incidental finding. So I think that's what this is. And the same with APC. About 10% of people who are of Jewish ancestry do have a very common mutation in APC that's very mild, has a very slightly increased risk of colon cancer. Again, it has nothing to do with prostate cancer. And so you might see these genes on here, but I think these are incidental findings. I just want to mention that so it's not confusing. I think this is, again, a reflection of the bigger panels that were done and not because it had anything to do with prostate cancer. But when we look at it down for just what the prevalence was, again, BRCA2 is the most common, followed by CHEK2, ATM. MMR stands for mismatch repair genes, so they lumped all the Lynch syndrome genes together, and so forth. So we really, again, it just highlights the fact that, they used to do testing just for BRCA1 and 2 alone. And I think this shows us that we really need to be casting a wider net to capture all the genes that have been implicated in inherited prostate cancer. So why should somebody consider having genetic testing done? I think this really is twofold. What is the implications for yourself? And what is the implication for your family? I think those are the 2 biggest questions I get from patients of like, why should I be doing this for me? Is it going to impact my medical care? And also, I'm very concerned about my family. What is this going to do for them? So if we think about risk, for impact for yourself, if you have genetic testing and test positive for one of these genes, especially something like BRCA2, then there are alternative treatment options that become available. Should chemotherapy ever be needed, then there's a very particular type of chemotherapy called a PARP inhibitor that takes advantage of the BRCA2 gene not working correctly and is very effective at killing cancer cells and leaving healthy cells alone. So it would make you eligible for that type of treatment, where there are other clinical trials that are looking at other particular genes and treatments for other genes if they're positive. So it really may open up a door for alternative treatment options. It also can tell us, is there anything else we need to be worried about for you? We know about the prostate cancer, but if you're positive for one of these genes, especially if it's something like BRCA2, there's also a risk for pancreatic cancer. There's also a risk for male breast cancer. And so special screening needs to be done in those situations to make sure that we don't get blindsided by something else, and we can be very proactive in our screening. So it really can impact your medical care, but also it can impact other family members. So if you test positive for one of these cancer genes, it means that your brothers and sisters have a 50% chance of having the same gene change, and it means that your children would each have a 50% chance of having the same gene change. And those who are also positive would have to do the special screening. You know, the thought is if we know you're at increased risk for certain cancers, then how do we watch you closely enough that if something were going to develop, you can catch it very early when it's treatable and usually curable. And so identifying other at-risk family members can really make an impact on their care. And identifying those people who are negative, you know, who would not need to do any special screening. It kind of, you know, their risk goes back down to general population risk. And so your genetic testing could have impact, you know, throughout the entire family. So I thought it might be helpful to kind of go through a couple of case examples of what this looks like in the real world. You know, so for the first example, let's see if we can get the next slide. Okay. So for this first case, this was a gentleman that came to me. He was a 51-year-old male with prostate cancer. It had a Gleason score of 8 and was multifocal. And his doctor referred him. He was currently in the treatment planning stage, was not sure exactly what treatment route was going to be taking. This was very soon after his diagnosis. The doctor was concerned because of the family history of breast cancer in his mom, ovarian cancer in his sister, and pancreatic cancer in the grandmother. The colon cancer in this patient's other grandfather is common cancer at a common age, probably just not anything that has to do with the prostate cancer, probably an incidental sporadic cancer. We were mostly concerned about the others that were highly suggestive that this could be a BRCA2 mutation in the family. And so the patient underwent a large cancer panel and indeed did come back positive with a BRCA2 mutation. They call those pathogenic mutations, which means it's cancer causing. We know the change in the gene makes the gene not work. And so this kind of opened the doors for the patient, you know, for making treatment decisions, but also really had a big impact on his family. His mom tested positive also for the same BRCA2 mutation. His sister tested positive also, but his aunt tested negative. So his aunt did not need to worry about any cancer screening, extra cancer screening for her. And it meant that aunt's daughter, this patient's cousin, was also not at increased risk, would not carry the BRCA2 mutation. So it really made a big difference in the family. The patient's children are too young to have testing at this point. Genetic testing is not recommended for children at this time. Not until they're age 18 for sure, but for women, screening doesn't change until age 25, and for men, screening doesn't change until age 40. And so we've got a lot of years for his kids who are 14 and 12 before they would need to consider this. There's not really any childhood cancer risk with BRCA2. So this had an impact on his medical management. He was going to be enrolled in a clinical trial for BRCA2 carriers, and it also had an impact on his family. So then if we look at the next case, I know this family is a little bit bigger, but, which makes it smaller. It's a little bit harder to see, but the little black arrow points to the gentleman who came to me. He's a 61-year-old male with prostate cancer. His Gleason score was a 7, and he was currently doing external radiation treatment. He was very concerned about his family because his dad had had prostate cancer in his 70s with a Gleason score of a 9, and 3 of his brothers also had prostate cancer, all in their 50s. He did not know what their Gleason scores were. And so the patient was very concerned. There was some distant family members also with cancer. And some of his siblings had other types of cancer, so they really wanted to figure out, why is this happening? So he underwent a prostate cancer panel, which included all of the genes that we talked about, and his results came back normal. They were negative. They did not find any mutation in those genes at all. So the patient is very suspicious that there could be something environmental going on in the family. This is what we would call sort of in that middle category where this does not look sporadic. It kind of looks hereditary. That's a lot of prostate cancer. This is something, a family we would say that has familial prostate cancer. So we don't have an answer as to why, but we think a lot of these familial cases, it might be something environmental that's making the people more vulnerable to certain types of cancer. And so the patient was concerned about the Air Force Base that he grew up near that had known contaminants, contaminated the water source for the town. And so was very concerned that that could have been having an impact for his family. Those things are super hard to test for. We don't have any proof. We can only do a lot of speculation, but we ruled out that this was inherited for the patient. So in the last case, this was a 60-year-old man who at age 56 had developed a sarcoma on his arm, and then a year later was diagnosed with metastatic prostate cancer. He was being treated with hormonal therapy, and his oncologist wanted to determine if there was an alternative therapy that would be appropriate for him, like a PARP inhibitor, to treat his cancer. The patient was also concerned about his family members. He had a lot of children and a lot of siblings, so that he was worried about their cancer risk and was hoping to provide some information to them as well. So he underwent a 21 gene panel that included all the prostate cancer genes. And his results were not negative, they were not positive. There was something called a variant of uncertain significance found in one of his genes called NBN, which has been seen in prostate cancer, but primarily is a breast cancer gene. But this variant of uncertain significance is when there's a change in the spelling of the gene, and they just don't know if that change causes cancer or not. Normally, it's just normal variation within the spelling of the gene, and the gene can still work totally fine. Although sometimes it can be disruptive and increase the risk of cancer. And when they don't have enough information to make the call, one way or the other, they leave it in the middle. They call it a variant of uncertain significance like this, and they continue to study those until they can say for sure if it's negative or positive. And 85% of the time, variants like this do get downgraded to negative. So we usually just ignore them and treat them like they're negative unless proven otherwise by the lab. So for this particular patient, it meant that there wasn't anything different that he qualified for. There was no alternative therapy, but it also meant that we have likely ruled out this is inherited, so we didn't recommend any testing for his children or for his siblings. So some of the other frequently asked questions that I get from my patients is, the number one is probably, will my insurance cover this? You know, can I get genetic testing? I've heard it's really expensive. It used to cost thousands of dollars to get just BRCA1 and BRCA2 done. But now you can get a multi-gene panel for as little as $250 at certain labs. Come way down. The testing technology has advanced so much that we can do it for much cheaper. So today, most insurances will cover genetic testing. What the laboratories charge insurance can sometimes be a lot more than $250, but most of the laboratories verify your benefits with your insurance to make sure that there's not going to be an out-of-pocket cost for you before they run your test. So usually you'll know if there and you can say yes or no if you're okay with it. A lot of insurance companies follow the NCCN guidelines. So if you meet those guidelines, you meet their guidelines for testing, and they'll cover it. So if you don't meet the national guidelines for testing, then sometimes it's harder to get insurance to cover the testing, and they could deny it. In those situations where we still feel like testing is important, or if you still want to have it done, there's always the test. So, and is there a certain genetic testing laboratory that I would recommend? There are many good ones. There's about 4 major laboratories that are all pretty on par with each other. So sometimes your doctor will have a particular laboratory that they prefer. And so the major ones are labs like Invitae and Myriad, Ambry, GeneDx. These are all great laboratories, and any of them are great. They all have a sort of different panels that they offer, and their costs can be slightly different. And sometimes some of the laboratories offer free family testing if something's positive, others do not. So they all have, things that are, benefits to using certain laboratories. But again, your doctor may have a particular preference, but I am comfortable using any of the major laboratories. The only thing I recommend against is if you get solicited by a laboratory or a company that says that there's been a scam that's been going around where people are doing sort of predatory testing where they're calling Medicare patients and saying, you qualify for this testing, you should have it done, I'm going to send you a saliva kit, and they charge Medicare $10,000 to do this testing, and even if you don't meet criteria. And so those testing laboratories are some that I would stay away from if they're soliciting you, and I would just use the trusted laboratories that your doctor recommends. So if any of this has sparked your interest, or if you're thinking to yourself, oh, I meet criteria, I should really consider having testing, or I'm concerned about my family history, what are the next steps? Definitely talk with your doctor. Your oncologist is going to be sort of the first person that you want to talk with. And they may want to refer you to a genetic counselor and to talk a little bit more, to do a deeper dive into your family history and talk through this a little bit more. You can see a local genetic counselor in person, or there are several genetic testing companies that do genetic counseling over the phone, like my company does. And so talk to your doctor and see what they think. That would be the first next step for you. And so I kind of want to open it up to questions. That's all that I had. So I'm happy to answer any questions that you all might have.
Yeah, this is Jan. We don't have any questions typed in the box yet. I have a feeling people will be most interested in the 3 case studies, 1, 2, and 3, because they always resonate more. But Joel, do you have any questions? And if anyone else has questions, if you want to type in that black and white circle, click on that. That would be great.
Sure, I absolutely have some questions. First, thank you so much, Susan, for a really great presentation. I really appreciate it. I do have a number of questions, but if Jan, you should interrupt me if any other people ask questions, please. Okay.
Sure.
So the first question, you talked about the different preferred labs, and you also mentioned that they have
Sorry, Joel, you're cutting out for some reason. Joel, you want to type your question?
And so all of the genes that we would be concerned about for prostate cancer are included because that's a very large panel. It's kind of a one-size-fits-all inherited cancer panel. So it has a lot of extra genes that might not be appropriate for the family, but it definitely would include the genes that we would want. And so the NCCN guidelines say if you meet the guidelines, you really should have, there's 21 genes that have been linked to breast, ovarian, prostate, pancreatic, and they list 21 genes. So those are the genes that we definitely want to make sure are included in the panel. Anything beyond that is kind of going to be extra or bonus. The bigger you get, the genes become more obscure or are not related to prostate cancer at all. They might be related to like kidney cancer or something like that, where we're not really looking at them. So as long as you have those 21 genes, and most of the, you can definitely ask your doctor about what genes are included and make sure that it's big enough. But I would say the trend right now is that most physicians are ordering bigger rather than smaller panels. And so usually what we want are included.
Great. Thank you, Susan. So I guess, we're all constantly bombarded by advertisements, to have our genetics tested. And I think, usually that was an ancestry and there's a number of things like that. Is there any value in that for people with cancer?
Well, when we think about, these what they call direct-to-consumer testing companies like 23andMe and Ancestry.com, they have a lot of genetic information that they can share with you, but the way that the laboratory is set up, that it can't be used for medical decision-making. So it's more like information, they call it for entertainment purposes. It might be interesting to get a little glimpse into your medical history, and do you have risk, for certain types of things, or it even tells you like what type of earwax you have. So a lot of times the genetic information that you're getting is not really going to help you make any medical management decisions, and really there's a disclaimer that you shouldn't use that information for medical decision making. When it comes to cancer risk genes, these types of laboratories are very limited in what they can look at. And again, there's a lot of concern that when like a company like 23andMe says that they look at BRCA1 and BRCA2 as part of their testing, it's not necessarily a complete picture. They only look at 3 very specific mutations that are common in the Jewish population. So the thousands of other mutations that could be present in BRCA1 and 2 are not evaluated. And so I would say if you're wanting ancestry information or just want to look, for, just for entertainment purposes, these companies are great. If you're looking for genetic information to direct your medical care, you need to use one of these medical grade laboratories.
Terrific. Thank you so much. Jan, it looks like there are some questions up, so I'm gonna mute for the moment.
Okay, yeah, we have a question from Ed, and he said, do we know that all the gene mutations that can promote prostate cancer have been found? I mean, I think I know the answer to that, but obviously, Susan, I'll let you answer that.
Mm-hmm. Well, we feel like we've got a good understanding of a lot of them, but it doesn't mean that there aren't new prostate cancer genes that haven't been discovered yet. So of the genes that we know about, we feel like we can analyze those genes very well and pick up something that's present in one of those genes. But I think you might be asking, are there other prostate cancer genes that we haven't learned about yet? And I think the answer is yes. There are other genes that we don't yet know about, and there are some studies going on right now, like gene hunting studies, where they're taking families that have a family history of prostate cancer and looking for additional genetic markers or additional genetic factors that may be playing a part. So like case number 2, when this family, clearly there's a lot of prostate cancer going on, this might be a family that would be a candidate to be a part of one of those gene hunting studies. So I think the story is to be continued. Yeah.
Yes. I'd like to add to that as an advocate, one of the things I like to explain to people is that everything we deal with is science, whether it's a treatment, a test, everything about cancer is science. So science is always developing. It's always moving. It's like a moving train. Sometimes it moves fast, sometimes it moves slow. Genetics, I would argue, is one of the faster moving areas of cancer science right now. So I would expect that with everything, we're constantly discovering new things, sometimes slowly, but sometimes fast.
Mm-hmm.
Ed has a second question here. He said, are the known mutations only in male genes, or can you inherit from your mother? I actually gave him an answer, and you can comment on this, Susan. I said inherited genetic mutations come from both mother and father. Clearly, BRCA2 is found in both. So you can comment on both his question and my answer.
Yeah, absolutely. So these genes are not linked to whether we're male or female. So men and women carry them equally. It's just the cancer risk is a little bit different whether you're male or you're female. So if you're a male and you have BRCA2, then the risk is prostate cancer, male breast cancer, and pancreatic cancer. If you're a woman, then there's a major increased risk for breast cancer, but ovarian cancer, women don't have a prostate, so they don't need to worry about that, but there's these other risks. So for case number 1, this man did inherit the mutation from his mother. And so yes, men and women carry them equally. You can pass them down to your sons and daughters equally. It's not dependent on whether you're male or female.
Thank you very much. Joel, do you have another question?
Maybe a little out of your wheelhouse, Susan, but we certainly hear a lot about a thing called gene therapy. So is there a step that if you find you have a mutation, that gene therapy may be something you should be asking your doctor about, or is that science fiction?
Well, for certain diseases, it's definitely not science fiction right now. They are looking at gene therapy, but usually these types of gene therapies are when the body is deficient in a certain enzyme, and you can put the gene back in to create an enzyme. So when we're thinking about cancer risk, it's a little bit different. So we're not at a place where we can give the person a copy of a normal gene and it fixes the problem. So for cancer risk, we are not there yet. I don't know if we will ever get there because of the nature of what these genes do, but I think the closest that we're getting is taking advantage of the gene being broken by giving an alternative chemotherapy. So you're not replacing the gene, but you're taking advantage of it being broken.
Terrific. So you've told me that I have some sort of mutation, and you also referenced the fact that that's when I start getting my family involved. Can you be a little more specific? So let's say I have a BRCA mutation. What kind of communication should I have with my family? What should my family be doing, and why?
Mm-hmm. Well, like we said, if you test positive for something and you're the first person in your family, we know that this came either from your mom or from your dad. And so there are going to be other relatives that are also at risk to have the same exact gene mutation. So your parents, your siblings, your children, all of them are going to be at increased risk. And so sharing that information with them, it's up to them whether or not they decide if they want to have the testing done, but providing that information is really important so they have the choice if they want to go through with it to determine, are they at risk or are they not? Do they need to do extra screening or do they not? And so typically when I provide a patient with a positive test result, we're providing them with some tools to help foster the discussion with their family members. Usually says like a letter that they can give to their family members that said, this mutation's been identified in my family. Here's some preliminary information. Take this information to your doctor and talk to them about getting tested, just to help facilitate that conversation. So again, sometimes family members don't want to know this information, and that's okay. That can be their prerogative. And I know that family dynamics can sometimes be very, very tricky when it comes to talking with other family members, but we really do encourage people who are positive to share this information since it can impact their health as well.
What kind of things can a family do if they are told that if the family member does have some of these mutations, if they wanted to take some sort of action? What types of things, if you can give some examples, could they do?
Mm-hmm. Okay, so well, for let's say you're positive and your sisters want to have testing done, and if they also test positive for BRCA2, their screening is going to change. They're going to be at increased risk for breast cancer and for ovarian cancer, and so they would need to do extra breast screening every year. So not only a mammogram, but also a breast MRI as well. To address ovarian cancer risk, they're a lot more proactive when it comes to that, because detecting ovarian cancer as early is a lot more difficult than it is for detecting breast cancer. So they do recommend having your tubes and your ovaries taken out preventatively. And so there's always an option for the breast tube, and there are some women who choose to have preventative mastectomies when they have a BRCA2 mutation. It's not a strong recommendation by the experts, but it is an option available to them. And so for women, that definitely changes things. For men, prostate cancer screening starts at age 40. And so there are some men in the family that might not be doing that, or their doctors might not be on board with prostate cancer screening, but having a G mutation means it's medically necessary for them to consider doing that screening.
So you're referring to things like PSA screens and possibly MRIs. Is that correct?
Yeah, typically they're recommending the PSA and the digital rectal exam at
Right.
least once a year. Yeah.
Right. And so somebody who has the mutation may want to talk to their doctor about, or have your kids talk to their doctor about screening earlier and perhaps more often. Is that correct?
Yes, absolutely.
Terrific. So you mentioned in reference to the DNA repair defect that women are at increased risk for breast cancer.
Mm-hmm.
What about males?
For BRCA2 specifically, that is one that we know male breast cancer is increased. We think the lifetime chance is about 6% for male breast cancer. So it's not as high as for women, where their risk is anywhere from 60% to 87% chance, but it's still significantly elevated over the general population risk for male breast cancer, which is way less than 1%. So for BRCA2, that male breast cancer risk is definitely there. They think that with CHEK2, it's also there, and possibly with PALB2 as well. They're still kind of learning more, but for sure BRCA2 is associated with male breast cancer.
So if someone has Lynch syndrome, and maybe you could just quickly review again what that was, because it was in the earlier part of your presentation, if you don't mind. You referenced the fact that their management needs to be changed or could be changed. Again, I know you don't do the management. Can you give us some ideas as to what that entails or would be?
Sure. So men with Lynch syndrome, essentially the biggest risk is going to be for colon cancer. And so colon cancer screenings need to be, with colonoscopy, needs to be done every 1 to 2 years. And so it's very different than the general population, where it's every 10 years, starting at age 50. With Lynch syndrome, you start much younger, starting at age 25, and colonoscopies are done every 1 to 2 years. So other GI screening, like upper endoscopy to look at your stomach, and if there's pancreatic cancer in the family, MRI to check your pancreas, those are all also recommended to be done.
Terrific. Good. You said that you follow the NCCN guidelines, and I think insurance probably follows them. So you talked about on the second point down, high grade Gleason 7 or higher prostate cancer. Is there a differential between a Gleason 4+3 or 3+4, or is 7 a 7 in this case?
7's a 7, yeah, in this case.
Right. So you're actually
7
defining 7 as being high grade.
That's what they say in the guidelines. Yeah.
That's interesting. Okay. So I think there was an earlier question kind of reflected this, but if you find no genetic defects, does that mean that we have no risk for inherited prostate cancer?
You mean if somebody who does not have prostate cancer gets tested, or let me make sure I'm understanding your question.
Well, yeah, if somebody gets tested and they don't, and they don't have any of the mutations, but they have, say, a strong family history, are they still at risk for familial prostate cancer, or how does that work? And they still need to change their testing or their management, or it doesn't affect it?
Yeah, it depends. it depends on who we've tested first, because if everybody with prostate cancer gets testing and everybody's negative, well, then we don't really have an answer as to what is causing all the prostate cancer. That's a familial case, and in those cases, everybody needs to be followed as they're high risk and needs to do the screening. It's different than if just somebody who has never had prostate cancer gets tested, but all the people with prostate cancer in the family have not been tested. We don't know in that situation, because is the person negative because there's a gene in the family they did not inherit? That's the case, they're not at risk at all. Or are they negative because there's not a gene in the family and then everybody's at increased risk? So the most informative person to test in the family is somebody who already has had the prostate cancer, to give us a clearer explanation of how do we need to address the risk in the family.
Right. And if somebody on this call thinks that perhaps they should get tested, what would you recommend they do?
First, would recommend that they talk to their oncologist about getting the testing done. Talk to them about it, see what the office's process is. You know, we always recommend considering talking to a genetic counselor first or as part of the process, and their oncologist may refer out to a particular place, or some oncologists do the genetic counseling themselves and just send out the test. So that's the best place to start, is talk to your doctor.
Terrific. Good. I think that exhausts my questions, Jan. I don't know, again, if you want to give the shot to anybody else left on the call, if they had any other questions.
Yeah, I'll definitely open it up. There's nothing else written in the chat box, but if anyone else has a question, let me try to unmute everybody just for a minute and see what happens. Some people might be muted themselves. I'm not seeing any questions. People can follow up with us by email, and if we need advice from Susan, we may email her too. But I hope this is helpful. I think one of the main things is just to understand it is somewhat rare. It is available to certain people per NCCN guidelines. A genetic counselor is for hereditary cancer, not necessarily tumor cancer, or tumor genetics, which is something different,
Right.
and that there are genetic counselors available. Susan, would you add anything to that?
No, I think that about covers it.
Okay, then I'm going to go ahead and close out. I will send a link to this video to everyone. And Susan, thank you again very much for your expertise, your comments, and to Inform DNA for lending you to us for today. So
Right.
Sure,
Thank you.
I appreciate the opportunity to do it.
Yeah.
Thank you, Susan. It was great. And I also want to just call out Jan, who's putting together all of our webinars. She's doing a yeoman task in times that are difficult. And thank you, Susan. I know that we're all under different stresses, and you rose to the occasion, and we appreciate it. Thank you very much to both Jan and to
I
Susan.
agree.
Very welcome. Thanks.
Thank you. Okay. Bye, everybody.
Bye.
Bye.